Guys, after subscribing to this channel, please make sure that you also press the bell icon so that no notification, no new video of mine, any educational video, is missed by anybody.
All right. So we begin tonight's discussion with paper number 2. Like I just told you at the very outset that last time the one which we had was actually paper 4 discussion, and tonight we'll be having a proper paper 2 discussion in which obstetrics basically is asked. DNB has a very this thing specific protocol for asking basics, and then obstetrics and gynae, and then mixed or whatever we say, the recent advances. But usually there's an overlap of questions, which is why it can be a little more confusing. And specifically paper 4, why? Because it has a mixture of obstetrics and gynecology and recent advances and contraception and stuff. So anyways, the one we discussed earlier before this week, okay, it has been properly written and labeled as paper 4 now. So the confusion is going to be put to rest tonight. We're going to be discussing paper 2, obstetrics. So let's begin. I hope all my new students tonight, they have already entered the chat room, because we'll be discussing together. If there's any student who's there on the Telegram channel who's not able to join, let me know. It's this thing will already come there on the top of the channel. Join. All you have to do is just join and just click the button. It will be very smooth after that. So it's a very easy way to join the class, right? So now let's begin. The easiest question to come was the etiology and the prediction of preterm labor. Now, the etiology of preterm labor, we've read so many times. A very basic theoretical question, very boring and drag question, I would say. 5-mark question. What I'm trying to give you from my class. See, I can just upload these questions. You can go ahead and you can just learn from these questions. What's important, what I'm trying to tell you is that what point the examiner wants to know from you. So there are two basic categories in this question: etiology and prediction. So if I was the examiner, I have 2.5 marks to each. And in these 2.5 marks, I at least expected to write a 5 points, right? So which is what I've tried to do over here. The etiology of preterm labor, basically, you see that infections can cause preterm labor. Cervical insufficiency can cause preterm labor. Any uterine abnormality can cause preterm labor. Multiple gestations can cause preterm labor. And certain things like, maybe some previous diseases, fibroids, these are the ones, autoimmune disorders, sometimes even gestational hypertension, diabetes, they can also cause preterm labor. So if you just write down these headings, the examiner doesn't go and read every line that you're writing down. Okay, so they say that you write horizontal and it's checked vertical. It's actually true. When I start seeing these answers, I want to see that whether they've been written, at least the headings are good or not. So the headings are telling me that this girl, she knows the answer, right? So infections, whatever infections come into your mind, you can write down the fungal infections, the bacterial vaginosis, or trichomonas, or chlamydia specifically, very notorious for causing preterm labor. Gonorrhea, not so common, but yeah, definitely chlamydia, the sexually transmitted disease, definitely. Cervical insufficiency, shortening of cervix or small cervix, or cervical insufficiency, cervical weakness, uterine abnormalities, Mullerian abnormalities, so many of them. You can also include uterine fibroids here. You can also include the uterine fibroids and maternal factors. Now, you know that multiple gestation. Why do you have a preterm labor in multiple gestation? Because the uterus that was there to accommodate only one healthy baby now has 2 healthy babies. So obviously, it's more distended. It's over-distended uterus causing pressure on the cervix, and that might just trigger the labor before term. Very, very obvious. Any overstretched uterus, polyhydramnios, uterine fibroid, anywhere where the size of the uterus is more than the size expected can have preterm labor. Apart from that, there could be some fetal factors, like maybe the abnormal fetuses, they also go in labor earlier. Okay, congenital abnormalities, excessive fetal growth restriction, fetal death, that can cause preterm labor. Placental issues like placental abruption or placenta previa, that can also cause early labor. Now, how would you predict this preterm labor? How would you do that? So first of all, you always start with history and physical examination. So now again, look at the headings. How? By history, by physical examination, by the cervical length measurement, by certain biochemical markers. And which is the most important biochemical marker for predicting preterm labor, guys? Quickly, everybody in the chat box. Most important marker, biochemical marker to predict preterm labor is, which we very often use. FFN, fetal fibronectin, with a very good, positive predictive value. And why do I say positive predictive value, not sensitivity? Is because it tells with a certainty of around 92% whether the preterm labor is about to happen in the coming 1 week. So fetal fibronectin is a pretty important marker. So let's go back there. Yeah. So you have and of course, uterine activity monitoring. So the uterus is irritable. And suddenly, after being irritable, suddenly the proper contractions have started taking place. The patient is definitely going in labor. And fetal assessment, well, that I don't think so, but yeah. We need to predict the preterm labor. We do that with the history, with the physical examination. So if the patient is coming from the high-risk history, suppose she already had a preterm labor before, or she is multifetal gestation right now, or she is having some comorbidity, Mullerian abnormality, you are predicting that, oh, could be she's a candidate of preterm labor. Cervical length is shortening. Fetal fibronectin, like I just said, is increasing. That is a marker for preterm labor. Of course, the contractions are definite markers of preterm labor. What you basically see is the cervical changes and you see the uterine contractions, isn't it? Not this much so much. Now, this, DNB, and I'm sure many other universities also, I have seen a couple of, question papers from the universities. They like to ask these case-based scenarios, which is very expected out of them because you are a postgraduate student right now. And if I were to judge you, I would want to judge you on your diagnosis and your treatment. So when a patient comes to you, case-based questions become very, very important and very relevant in your case. So a 30-year-old second gravida reported to labor room, 30 weeks gestation with a preterm labor. What do you want? Now, guys, I have taught you preterm labor. Many of you have already got my theory course, and you've seen that preterm labor, there are 3 very important things which I have time and again given importance to. Can you please quickly write down in the chat box what is exactly the basic management? Just the basic. I don't want any doses. Just tell me the basic management of anybody who's in preterm labor. Quickly. The 3 or 4 important things that you would want to do, you want to give to a patient in preterm labor. Quickly. Come on, guys. The same 2, 3, 4, 5 students who have been answering always, they become 7, 8 now. But the same students have been answering. I want everybody to participate. I'm sure you would, by participation, you are going to remember better. Believe me, by writing down, things get, etched in your mind. So, okay, one is steroid cover. Yes. Preterm labor, the moment you see a patient is in preterm labor, you give steroids. Yeah. You would give tocolytics. Absolutely, I agree to it. You would think of antibiotics, maybe, yes. And if she's in real preterm labor, probably you'll give a Maxalf, right? So this is why I added the 4th one. It might not always be true, but anywhere between 32 weeks, I would think you would probably give her a Maxalf dose. But only Maxalf is when there's imminent delivery. If you start giving her Maxalf only because she's having an irritable uterus or uterine contractions, but with no cervical dilatation, you're looking at a really long road, okay? But if you start giving Maxalf to her at 4 centimeters dilatation, which is the recommendation by RCOG, then you are actually justified in giving her that to less than 32 weeks of gestation. All right. Some people say 30, some people say 32. Recommendation is actually 30 weeks. Now, based on what you answered, is my answer prepared? See. The tocolytic therapy, you just said, okay, what I've done is just added a doses and agents. Then I go to the steroid administration. Absolutely what my students have told me, that only I've written, okay, nothing else. And antibiotics, like you just said, okay. Maxalf, yes, no, maybe. And obviously the monitoring. So what they want to see from you when they ask you for preterm labor management at 30 weeks, obviously you don't want her to go, in labor. You would want to maximum, give benefit to this baby who's coming out at 30 weeks. So the idea of tocolytic therapy is not to enhance the baby in utero. The idea of tocolytic therapy is to give the steroid cover a couple of days so that the baby gets maximum benefit out of the steroid cover. So most important preterm labor management is actually giving steroid cover. The moment you feel that this patient is in labor, first thing you do is give steroid cover. And if she's going in advanced labor, you already started her on tocolytics, so that the effect of steroids gets some time. Now, with this thing said, tell me the steroid maximum benefit starts at what time of steroid. For example, I have given at 9 a.m. today steroid to this patient. If she delivers tonight at 9 p.m., do you think the maximum benefit of steroid she's going to get or not? And if not, then when is she going to get the maximum benefit? Ideally, when should she deliver so that she gets more benefit of the steroid cover? And my time is 9 a.m. today. Okay, it's 20th April. So she gets steroid cover at 9 a.m. on 20th. She's in early preterm labor. And I wouldn't want her to deliver tonight because I feel that the steroid cover has not yet kicked in. So the time of kicking in of the steroid to give beneficial effect starts after 48 hours, guys. The peak action starts at 48 hours, that is 2 days, stays on only till 1 week. So after 1 week, the effect is almost nullified. So if you want maximum benefit, she should deliver after 48 hours, preferably on the 3rd, 4th, or 5th day, and then the decline starts. So that's the idea. So this is the reason why if you see atosiban, which I had talked in detail to you when I was talking about preterm labor, it is only given for 48 hours because it's a very expensive this thing tocolytic, and obviously a direct antagonist to oxytocin is a beautiful drug, but it's given as a bolus injection of 6.75 milligram, and then finally maintenance dose of 18 milligram per hour, but only for 48 hours total. The reason being the effect that it takes for the steroid to act. You get that much window period. That's it. And of course, the doses of terbutaline, nifedipine, indomethacin not given so much, but definitely atosiban has to be mentioned somewhere. Steroid administration, I'll be talking in detail about later on because there's a question about it. And antibiotics, if there are signs of PROM, then you can give ampicillin and erythromycin that can be initiated. Of course, you would want to see the cervical length. You would want to predict with the help of cervical length how to whether this patient is in frank labor or not. Correct?